and probably the next medication we're going to talk about, and you mentioned ezetimibe. So we can combine a couple of pills. And maybe we can talk more about ezetimibe for people to have a better understanding. Certain patients, they tend to be hyperabsorbers of, oral intake of lipids, cholesterol, and ezetimibe has been used for those individuals. How have you utilized ezetimibe, and who would be relatively ideal candidates for taking ezetimibe?
So ezetimibe, used to be known as Zeti. It's been on the market for over 20 years, and I've used it routinely in those 20 years. And the Improve It trial really showed, the benefit of adding ezetimibe on board of statin therapy. People had less cardiovascular events with it. So it's in that category where you actually have, actual hard outcomes with the medication. Doesn't just make the labs look prettier. So ezetimibe doesn't always work that great as monotherapy. It's really good at add-on therapy often, but sometimes if you use the Boston Heart Lab panel, or there's other companies that do the cholesterol balance test. I'm using an analogy, and we'll run through it here. Is that think of cholesterol as water going into a bathtub. To prevent the water from overflowing, there's three main things you could do. You could either shut off the faucet so less water goes into the bathtub. That's basically using a statin or bempedoic acid, which is Nexletol, red yeast rice, bergamot. Dial back on the cholesterol production so less water goes into the bathtub. You could open up the drain. That's what the PCSK9 inhibitors do. Express more LDL receptors, plug those ApoB particles out of circulation. And then once the water's into the drain, ezetimibe makes sure that the water goes out to the sewer pipe. And approximately 20% of the population, people are hyperabsorbers of sterols, and it's the sterols that their body is producing. It's not necessarily the sterols that they're eating. And so the cholesterol is getting pumped back in to the portal circulation. And those people, it happens in everybody, but those people tend to be more hyper responder. And so ezetimibe basically closes the door and prevents those sterols from being reabsorbed. So if your body said, get rid of you, it gets rid of it. And so, it's not as potent as statins, but it's often, pretty good to add on to those people. But if they're a hyper absorber, they tend to have a hyper response to ezetimibe.
No, definitely. And it's good to combine a couple of medication. And if you're having muscle pains, myalgias, then you can play around and get your LDL particle levels, ApoBs down much more appreciably if you're having combined therapy, especially if you're having certain symptoms. We talked about PCSK9 inhibitors, and those are medication that can technically lower your ApoB, LDLC quite drastically. The reason it's not, I think, that common is because you need to really jump through a lot of hoops through insurance to actually get that prescribed. But what is the scenario that in your practice that you have to start individuals on these medication?
There's three on the market currently. There's Repatha and Praluent. Those are usually twice a month, or there's some variants of them that are once a month subcutaneous injections. There's also ilasclerin, which is a twice a year infusion. And so because they are not a pop a pill, they tend to be multi-$1,000 a year drugs if insurance doesn't cover them. And so most of the time, you have to have failed trials of at least two classes of statins. Often you've had to fail ezetimibe getting to goal. And then PCSK9 inhibitors, often will be covered by the insurance companies in that situation. But they're mostly add-on therapies for people who are at maximally tolerate statins and not getting to goals, or they just can't tolerate statins at all, and then they get added on. They're very potent. You sometimes see ApoBs, being lowered 40, 50% with these medications, and not particularly a lot of side effects with it. So, I don't use them for everybody, but they do work in the people that are good candidates for them.
No, definitely. Thanks for watching, and I appreciate you as a valuable viewer. And if you liked this segment, you can watch all of the different individual segments or the whole podcast to have a broader understanding on this topic. Just check the links in the description or what you see on the screen right now. I'm Dr. Umar Khan. Looking forward to seeing you again. Thank you.